Now, I would like to invite Dr. Shilanjan Rai, who will be discussing on post-stress diastolic echo.
Distinguished dignitaries who are present here, from the very interesting discussion on cardiac muscles, I will be discussing on a small part of the diastology, though very important part, that is a stress diastolic echo or the post-stress diastolic echo. And it is particularly very important in nowadays as the idea about the heart failure with preserved ejection fraction is gaining importance, and we are getting an insight about this novel condition, though it's very, very common, as we all know. Now, diastolic stress echo, as we all know, the importance of diastolic dysfunction for the symptoms of shortness of breath, exertional fatigue, or poor exercise capacity is increasingly recognized, and diastolic dysfunction is one of the most important causes, almost attributing to 40% of the patients who are presenting with clinical heart failure. Now, as patients with diastolic dysfunction, many of the patients may have similar hemodynamic profile in terms of cardiac output and filling pressures at rest, like that of healthy individuals. This stress echo becomes very important to distinguish between these normal individuals having a normal diastolic function at rest and the patients having masked diastolic dysfunction, which may be unmasked by this stress echocardiography. So diastolic stress refers to the use of exercise Doppler to detect impaired diastolic function reserved and resulting increase in the LV filling pressures in patients with unexplained dyspnea or subclinical diastolic dysfunction. And it is mainly of value in the patients with suspected heart failure with preserved LV ejection fraction with borderline diastolic dysfunction. Because many of the patients have signs and symptoms of heart failure or HFF, they fall into the gray zone of echocardiographic diagnostic parameters such as E by E prime between 18 to 15. Hence, a technique that can accurately characterize these borderline patients could be of great importance. Now, several studies have shown that these left ventricular diastolic alterations are more manifest during exercise than at rest in HFpEF. The basic physiological principle, as we all know, I am not going into details of this, that when a normal subject exercises, they can increase their stroke volume without significantly increasing their filling pressures because of augmented myocardial relaxation along with the more powerful early diastolic suction. Reduced LV diastolic relaxation is one of the earliest manifestations of this myocardial dysfunction. Myocardial relaxation is presumably the first and consistently reduced in all forms of myocardial disease, first to be affected, be it hypertensive heart disease, myocardial ischemia, or HCM. In normal subjects, the early diastolic E velocity increases and simultaneously the mitral annular E prime velocity also increases proportionately, so the ratio remains unchanged from the resting state to the exercise. But this augmentation of the myocardial relaxation, as it is reflected by the E prime velocity, it is limited in the patients with diastolic dysfunction. So the E by E prime ratio increases with exercise. And it has shown good correlation also, this exercise E by E prime ratio with invasively obtained pulmonary capillary pressure, left atrial pressure, and LV mean diastolic pressure with variable levels of effort. So the indications is that it is indicated in patients when resting echocardiography does not explain the symptoms of heart failure or dyspnea, especially with exertion. The patients with completely normal hearts and diastolic function at rest with preserved E prime velocity, in whom where the E prime is more than 7 or the septal E prime more than 10, they need not undergo stress testing because it is highly unlikely that a patient having completely normal diastolic function will develop diastolic dysfunction and elevated filling pressures with exercise. So they are excluded, completely normal. Similarly, the patient who have already significantly abnormal baseline findings at rest with elevated LV filling pressure should not be referred for exercise testing because it is expected they will almost certainly increase further with exercise. So the most appropriate category of patients is the patients with a grade 1 diastolic dysfunction, which indicates a delayed myocardial relaxation and normal LA mean pressures at rest, but where higher grades of dysfunction may be unmasked during exercise. So diastolic stress echo, when we are doing in certain subsets of the patient presenting with typical symptoms, what happens, there is a decrease in the E prime velocity, there is an increase in the E by E prime and increase in the pulmonary arterial hypertension. We can stamp this patient as heart failure with preserved ejection fraction when the average E by E prime is more than 14 or the septal E by E prime more than 15. These are few parameters that we should keep in mind while we are doing the exercise echo. Peak TR velocity more than 2.8 and rest septal velocity less than 7. So you can see in this example, a patient in the normal baseline echocardiography at 25 watts of exercise and 50 watts of exercise. In normal baseline, there is only a grade 1 diastolic dysfunction, and the E by E prime ratio comes out to be 12. But as the patient exercises to 25 watts and graded exercise up to 50 watts of exercise, there is a significant change in the mitral inflow pattern from normal, reduced diastolic compliance to a restrictive filling pattern, and there is a significant increase of E by E prime to 24, thereby unmasking the underlying diastolic dysfunction. Now, supine bicycle ergometer is recommended modality for diastolic stress echocardiography assessment. It allows the acquisition of Doppler recordings throughout the test and also non-invasive assessment of the exercise diastolic function reserve. Treadmill is an alternative, but throughout recording is not possible, but it is also an alternative because diastolic abnormalities may persist even after the exercise. Also, patients who cannot exercise, preload augmentation by passive leg rise is an option, and it is usually done by exercise. It should be kept in mind, not done using dobutamine stress like in RWMA assessment, because the administration of the drug does not simulate the day-to-day physiologic stress. So this is a stress lab where the patient is being doing a bicycle ergometer testing, and various stages of exercise is being done, and also the Doppler parameters being assessed during recovery. So this is a stress protocol of test. I am not going to details of this. Few points to be kept in mind: that the images, the Doppler parameters to be recorded at baseline at low levels of exercise, peak exercise, as well as during the recovery period, and variables of E by E prime usually recorded when the heart rate is between 110 to 120, because E by E and the A velocities, they are not fused at this heart rate, and if the heart rate goes beyond 120 or 110, usually these two waves become fused, and it becomes difficult to assess. Post-exercise assessment during the recovery period can be performed, particularly when there is an abrupt increase in heart rate with low levels of exercise. In certain cases, as we can see, that at the recovery period, we can also go for NT-proBNP assessment after exercise, particularly in the patient where the rest NT-proBNP is normal. That can also give a additional clue to the diagnosis of heart failure with preserved ejection fraction. The test is considered definitely abnormal when the patient is meeting at least 3 conditions, that is average E by E prime is more than 14, or the septal E by E prime ratio more than 15 with exercise, peak TR velocities become more than 2.8 meter per second with exercise, and septal E velocity less than 7 per second, centimeter per second, or only if the lateral velocity acquired less than 10. However, this is an important point that one should be cautious. No conclusion should be drawn based on the isolated TR velocities, because significant increase in the pulmonary blood flow can also increase the TR velocity. So it should be corroborated with associated E by E prime velocities. In indeterminate patients also, an invasive hemodynamic investigation may be necessary. So this is also another example of positive stress investigations. We can see that in this patient, initially the E prime velocity of 5 and the E velocity of 50, that is at rest, the E by E prime ratio was 10, and the TR jet was 2.6, that is the PASP coming out to be around 28. After the exercise, at the peak stage of exercise, the E prime remains the same, whereas the E velocity significantly increases to 95, so the E by E prime increases from 10 to nearly 18, and the TR velocity becomes 3.5, that is 50, PASP comes out to be 56. So these indeterminate test diastolic function at the rest becomes quite evident and prominent when the patient is exercise. The same thing, same example, this is the baseline Doppler study showing grade 1 diastolic dysfunction and the E by E prime ratio of 12. At 25 watts of exercise, that is at the intermediate levels of exercise, there is an increase in the E velocity, whereas the E prime remains almost the same, which increases the E by E prime ratio to 15. Whereas in the recovery, that is even after the patient has exercised, there is a further increase in the E value, which with an increase of E by E prime to 19. So even after the cessation of exercise, there has been an increase in the E by E prime ratio. So what does it, additional information that it adds? First thing is that several studies have validated that E prime is a measure of left ventricular filling pressure, almost corroborates with the invasively measured LV filling pressure using simultaneous exercise echo and catheterization studies. So the reproducibility of these results is quite reliable, addition of E by E prime during exercise echo, it improves the sensitivity for diagnosis of HFpEF compared with the resting assessment. That is a very important in, and it holds true for most of our HFpEF patients. And also the specificity of the HFpEF diagnosis can be increased if tricuspid regurgitation velocity also increases above the normal range with exercise. So by both sensitivity as well as the specificity of diagnosis of HFpEF can be increased with when we combine this exercise echo with normal resting echocardiography. And it also gives some additional prognostic information in above to the wall motion study and other echocardiographic indices. Progression of diastolic dysfunction grade also predicts the future development of new onset heart failure. Higher the diastolic dysfunction grade, higher is the chance of future progression to heart failure. So the key points that needs to be emphasized is that diastolic stress testing is indicated in the patients with dyspnea and usually in grade 1 diastolic dysfunction, that is in the mid part of the spectrum. In the either part of the spectrum, either it has not to be done, that is it is essentially normal, or patients having higher grades of dysfunction at rest, it is normally obvious. It is performed either with a supine bike or treadmill bicycle ergometer. At rest, the mitral E and annular E velocities to be recorded along with the peak TR velocities. The same parameters recorded during exercise or 1 to 2 minutes after termination of exercise also when the E and A velocities have not merged, because increased filling pressure usually persists for few minutes even after patient has terminated the exercise. And the test is considered positive when all these 3 parameters are met. Thank you very much.
Thank you, Shilanjan, for beautifully illustrating the evidence and increasing the sensitivity and specificity of demonstrating diastolic dysfunction, detecting heart failure with preserved ejection fraction who are not diagnosed by ordinary resting echo. Thank you.
Thank you.
Again,
Dr. Shilanjan, I want to make a comment that you have initially excluded the diastolic stress test among the patient with normal diastolic function.
Yes.
I think this may be true in the current time, but in future you have to include this patient also, as we have seen in other part, that is strain imaging has revealed abnormal systolic function even in a normal systolic.
Definitely, so I think the
So
patient who
this
is
part, I think,
showing signs and symptoms of heart failure and even with a normal diastolic function,
if
stress,
there is a subset for that,
yes, for
you
a certain
have to
substrate,
include, even if the diastolic function is normal. This is number one. Number two, whether atrial fibrillation, how it influences the diastolic
atrial fibrillation,
stress.
diastolic dysfunction will be an entirely different type of assessment. It requires different parameters to be assessed because conventional measures of diastolic dysfunction assessment does not hold true. E by E prime can be measured, but ideally it should be measured in a single frame, where in a single cardiac cycle, the E velocity as well as the E prime is measured. That can be measured in certain machines, which is not commonly available. Other parameters of diastolic dysfunction like the pulmonary venous, reversal, flow reversal, then DT value, the deceleration time, reduction in the deceleration time, all these parameters has to be measured in atrial fibrillation, apart from the conventional parameters.
Thank you, Shilanjan. Any other comment from the floor? So, thank you. So, we will call our last speaker, Dr. Anuruddha De, veteran Anuruddha De. So, he will speak on a new look at the atrium synesthesia.